So welcome to Ghent. We are just going to talk to you a little bit about our approach to polypectomy. So we aim at GIEQs to give you a clear evidence-based algorithm for any colon polyp, how to make decisions and how to resect it. Of course, the question is it for endoscopy or surgery? An important one. If it's for endoscopy, should I be doing it or should someone else be doing it on a different day? And if I am going to do it, what technique should I use and how practically should I best approach it? So should I perform it? What technique should I use and how practically do I perform it? So the issues around these certain parts of the discussion are, if I should perform it, well, is there deep invasive cancer? And maybe it should never be performed by endoscopy. We did back in April this year, about decision-making in polypectomy. You can also check that out at your leisure by going to GIEQs.com and having a look at the link there. And then more practically, how do I perform it? And that's really what we want to focus on today, a deconstructed approach to how to tackle a colorectal polyp that you think you should have started that doesn't contain submucosal invasive cancer. Some basic terms which you can review at your leisure. So quickly to look at technique, our view is under 10 millimeters as per ESG and many publications, you should be using cold snare for pretty much everything. It says also serrated polyps, if they are non-dysplastic, should be considered for piecemeal cold snare polypectomy if they're more than 10 millimeters or piecemeal EMR, and dysplastic piecemeal EMR. Once you apply the classification system we'll show you shortly and you come out with a low risk of submucosal invasion, you should go piecemeal EMR. Otherwise, you should go en bloc EMR or another en bloc technique. So have I confused you? Okay, that's fine, because I think you're in the right place for being confused. The most important thing to say is that this is 90% of everything you will ever do. Even if you're not in the training center or tertiary center, this is probably 95, 96% of everything you will ever do. Cold snare polypectomy. My trainees say to me today, you never let me touch a hot snare. That's true, because you don't need to. 98% of it is included in this piecemeal EMR, and so I'm not going anywhere near ESD or any other en bloc technique. Still 98% of all colorectal polypectomy falls into this group. Therefore, the high-risk SMI and the difficult polyps that everyone's always talking about in symposia is 2% of colorectal polypectomy, not particularly relevant to the everyday endoscopist.
And that would be just coming at the lesion straight ahead. Now, what they tried to do was a different technique, which is what we call a pivot, which allows you to remove the polyp potentially in one piece or possibly in two pieces, where you, as you can see here, you're going to embed the snare and then pivot the snare from being in front of the lesion. You're going to move the scope such that the longitudinal axis of the snare is in the same plane as the fold itself. And that allows the snare to grab the lesion from both the oral side and the anal side simultaneously. And as it closes, it aligns itself against the muscle fibers which follow that line of that fold. And it reduces the likelihood of perforation because you're unlikely to entrap the muscle using this technique. And at the end of the day, we use the phrase, there's many ways to do polypectomy. And as long as the procedure, and this is the critical bit, it's safe and complete, at the end of the day, the outcome doesn't matter. What you're talking about here is trying to improve your efficiency and effectiveness of your polypectomy, which will reduce the time and minimize any risk to the patient. And the risk to the patient include the immediate complications and also the long-term consequences of recurrence if you get this wrong.
Another thing maybe we didn't mention here yet, which we did say on the live, was that when it got difficult, I think you took over for a second, and what you did first of all was put it in the 6 o'clock position, so rather than the 3 o'clock, and this also made it a lot easier. So whenever you're struggling, I think reposition is one of the first things to do. Make sure you have it where you want it, and then there is also the snare tip. What Michael told us was to lean against the bed with your leg, so you really are stable yourself before you start your snare tip soft coagulation.
you need the torque to be as free as possible. And when you've got the torque, when you've got the scope externally tucked under the arm like that, then when you're applying clockwise torque, the scope is going to push up against the forearm, and that's going to make it much harder to apply that clockwise torque. And we often see endoscopists really kind of grabbing the scope to try and torque it because they're kind of just pushing the torque against their forearm. When they go underneath the scope, the weight of the scope then allows that torque to be applied more efficiently. So definitely we would normally go for the scope going, the arm going underneath the scope.